Town. Yes. Good afternoon, ladies and gentlemen, and a warm welcome from a magnificent Cape Town. Clear skies, 30 degrees Celsius, and not a cloud in the sky. It's wonderful to have so many of us present over here. My name is Peter de Jong. Our presenter this evening is my co-chair, Professor Stephen T. Jeffery. I always rated him as one of the 10 best urogynecologists in Cape Town, and it's a great privilege to have him over here with us, speaking about recurrent urinary tract infections in women. Our sponsor this afternoon is the Cape Town Pelvic Floor Foundation, and I'd like to thank them very much indeed for sponsoring this presentation. Our technician is Chris, and a warm welcome to you, Chris, and thank you for all your efforts in getting this off the ground. So, Steve, I'd like to just introduce this by saying this is a very important clinical problem. Hardly a day goes by without a woman having urinary tract infections and recurrent urinary tract infections. Doubtless, you're going to define the problem, and then we're going to start. Without further waste of time, Steve, would you mind us if we interrupt as you go along? I mean,
no, we can, Pete. Just technically, it's a bit difficult because presenting from this talk and then looking for the questions.
No, all right.
So we'll have to. But you can interrupt me, obviously, no problem at all.
I mean, you're a married man.
As you would.
You're used to interruptions.
Yeah.
So, without further ado, recurrent urinary tract infections in women.
Yeah. So thanks so much. I do have a disclaimer, and that is, I don't have all the answers to this very complex clinical problem that we face on quite a regular basis, and so but I do feel that over the last year and a half or so, we have made some good progress in the management of this very difficult condition. So so let's just get to the next slide. So UTIs are a big problem, not only in the recurrent type, but also just generally, and at least up to 80% of women will at least develop a UTI at some stage in their life. More than 25% at some stage will indeed have a recurrent UTI. And unfortunately, it affects women of all ages. There'll be teenagers that get recurrent urinary tract infections, women in their 20s, 30s, 40s, 50s, and all the way up to women in their really old age, where they still have these ongoing UTIs. So it's a really complex problem. It does lead to the use of lots of antibiotics, which in itself is a problem. Using lots of antibiotics puts people into a vicious cycle of destroying their microbiome, which is a very important part of the defense and resistance to urinary tract infections. It leads to lots of GP gynecologist visits as well. GPs in themselves are often very frustrated by this condition, and the patients do find themselves rushing back to the GP. Even if they see us, they'll feel bad coming back to us. It might not be very practical for them to come and see the gynecologist or the urologist, and it does lead to lots of frustration. So UTIs, there is a spectrum of UTIs, but for today we are going to be looking at this whole condition of the recurrent urinary tract infections, and as I say, we are looking specifically in women. But as you can see, there's a spectrum of these conditions, and we're not really focusing too much on pyelonephritis and cystitis, but really looking at the recurrent conditions. But again, very frustrating. These are, without a doubt, I think the most difficult patients that I do see. Difficult really because they are frustrated. They've often seen a number of practitioners for that, and I'm not fooled into thinking I'm the last one they're going to be seeing. So I often see myself as being one of the sequence of doctors that these patients do see. But I think we have got enough new stuff and new ways of looking at this thing. So I think it's good to just bear with me today, and you can actually see how I am looking at this problem. And so it's not time to just go and sit down in the corner and give up on these patients. There is a lot we can do to treat them. So this is important because we know that E. coli is responsible for about 80% of recurrent urinary tract infections. But we know that Klebsiella has become quite important, and we're seeing a lot of resistant Klebsiellas. Are you seeing that, Pete?
All the time, Steve.
Yeah, so I think Klebsiella is a big problem. Ephocalus and also Proteus responsible for some of them, but these are the most common bacteria. But we all know, there's a whole array of bacteria that you see causing these recurrent infections.
Steve, these E. coli that you say, are they gut-acquired E. coli? Do they come from For example, women wiping in the wrong direction, or are these just random E. coli? How do they get into the bladder? The second question I've got over here on my WhatsApp is, do they all have different causes and etiologies? For example, do women in pregnancy have a particular cause? Do young women have a particular cause? Do old women have a particular cause for UTIs?
Yeah. So when patients ask me that question, I actually show them this little model that I have on my desk here, Pete. And I show them the complexity of the problem. I mean, you've got the bladder over there. Sorry, I can't, I'm doing in reverse there, but there's the bladder, I say. And I mean, you've got the vulva, you've got the rectum, you've got this very short urethra. I mean, the woman's urethra is about 4 centimeters, whereas the male's urethra is much longer. Then you are reliant on the microbiome from the rectal area. You're reliant on the pH of the vulva. You're reliant on the anatomy. You're reliant on the emptying of the bladder, and we're going to look at all of that in detail.
Oh, okay. Thank you.
Yeah, I mean, so it's complex, and that's why treating it isn't easy, because you are having to try and guess to see exactly what's causing this problem in the patients. No talk would be complete without a definition of what it is, but this is again a little bit more academic in a way. And but if the patient's had about 3 UTIs in a year, according to the European Association of Urology, that would then be called a recurrent UTI, or 2 in the last 6 months. The American Urology Association says 2 separate culture-proven episodes of acute bacterial cystitis associated with symptoms in 6 months, or 3 episodes within 1 year. So it is really nice to have a culture at some point in the patient's history. It gives an idea as to what bacteria you might be dealing with. If you see that it is E. coli, that's quite nice, because you know that you still have some strategies associated to go with. It's also good to know that this was indeed something that was proven, because sometimes it's not recurrent cystitis. If they give you this interesting history where they say, well, they go to the GP, they've got bladder infection symptoms, and then the GP dips the urine and it's normal. Well, then you need to start thinking about possible interstitial cystitis rather as a diagnosis. And so that is the way I think about the whole thing.
Steve, just back to the GP issue, what you say. No, not that far back, Steve.
The GP issue?
Yeah, no, just go back to where you were, is what I mean. You've gone back to the beginning.
Where are we going back to?
There.
Oh,
there.
Okay.
Now, when they go to the GP, I often have people that come to me and the GP has done a dipsticks or even casualty, and there's leukocytes, and they think, well, this is a UTI. Is it or is it not, if they have positive for leukocytes? What dipstick is characteristic of a urinary tract infection? Is it blood or is it nitrites? Which one would you classify as a UTI?
So look, Pete, we know that the dipsticks is a screening test. And I send off lots of urine cultures from my office. I don't really often rely on the dipstick in many patients. So you need to decide whether you're going to do an MCNS. I think it's good to do one if the patient has a history of recurrent UTIs and they come to see you, they've got something in the dipsticks, then absolutely get it tested again. I place probably the most emphasis on nitrites or nitrates, simply because you know that is probably a little bit more of a more specific change. Leukocytes, I mean, sometimes you look at the colors and you kind of squinting and trying to decide if it is positive or not as well. But yeah, so it's just a guide, and you have to feed it into what the patient's giving in terms of symptoms as well. So it can be quite difficult to
and if they've got that characteristic smell, so if it's nitrites and it smells, and anybody that smelled a UTI, it's like a bit of an asparagus-y, stale, but a very sharp smell. I would say that probably means that she has a UTI. Certainly in pregnancy, and they want treatment, that would warrant it. Don't you think?
Yeah, absolutely. I mean, the pregnancy issue is quite
Oh
important.
no, look, that's a bit off piste. We're not
no, but it is an important one. And I mean, you need to treat these patients. We know that they then have high risks of preterm labor, and some other associated issues. So it's actually a very important thing you bring up. But that's not my area of expertise at all. But yeah, so when you see these patients, obviously we need to do a proper history, and do think about things like bladder cancer, especially someone who's a heavy smoker. Think about that. Personally, probably don't see a lot of TB bullets here, but I do take a history quite specific for interstitial cystitis or painful bladder syndrome. That's what that ICPBS stands for. Ask them about their ability to empty their bladder. In patients who've been in hospital, we do see a lot more UTIs. Many of them have been catheterized. We've done pelvic floor surgery on them, or even non-pelvic floor, but gynae surgery on them. With catheters in and out, give them a shot of Augmentin or cefuroxime on the table. Again, you're then starting to kill off the microbiome, and these are the patients that then come back with a UTI. And then think about other surgery that they might have had that might indeed be causing UTI. And so you do get patients who might have a little bit of pneumaturia due to diverticulitis that's then causing a little fistula, and you get pneumaturia. So those are the kinds of things you do need to think about.
Just before you go further, hematuria. We didn't talk about hematuria.
Yeah.
But surely that is one of the most.
No, well, that's obviously part of your routine questioning, and always ask the patient about that.
And pain. I mean, hell, it's painful.
Very important. Yeah. So those are the things that you do need to think about as well. Risk factors. So we do see a lot of patients who have sexual intercourse associated urinary tract infections, and all the classic term of honeymoon cystitis. So that is something that we do find a lot of, not only young women, but also in the postmenopausal women too. And then atrophic vaginitis is a very important cause of recurrent urinary tract infections in older women, and invariably the cause that you need to treat by default in all these patients.
How does a spermicide cause urinary tract infection? Or is it just that you use a spermicide? Is it like an association with more intimacy, or does the spermicide in itself?
Yeah, I think it irritates the vaginal skin, and it can potentially affect the microbiome, affect the the resistance to the infection, and then lead to increase in the UTIs.
So basically, the best spermicide is the one that has, what does Dr. Rudolph say? Not a water-based, a silicon-based. So that's the one.
Yeah, that would obviously be with the more lubricants. So there's a patient who got a lot of atrophy, and trying to get it from this to this is what you often find. So the reason you get more UTIs in patients with vaginal atrophy is that the pH changes. A very atrophic vagina doesn't produce much glycogen, and it's the glycogen that gets converted to glycolic acid that produces a more pH or a lower pH vagina that then enables these patients to be more resistant to UTI. So there's a lot of scientific sort of ideas behind why an atrophic vagina leads to more recurrent urinary tract infections. I do also, in my practice, place quite a lot of emphasis on patients with prolapse, and especially patients who've run the gambit of different GPs, different urology and gynecologists, still get a lot of recurrent urinary tract infections. Look for prolapse. I'll often do an ultrasound, and you can actually see a relatively big cystocele with a transperineal ultrasound. And I do go and offer these patients surgery for that. Indeed, we did one yesterday. A patient who had quite a big prolapse, lots of recurrent UTIs, not getting any progress, even with macrodantin prophylaxis. And we went and did a prolapse surgery.
Is that because they're carrying an increase to post-void residuals,
yeah.
Steve?
So it's the residual, and it's that cystocele that tends to, prevent them from emptying the bladder properly. And it wouldn't be wrong to even do a sacrocolpopexy on these patients, which I do. It gives a very nice support to the anterior vaginal vault, although you can go and do a simple vaginal prolapse procedure on her. But these patients are often very happy when you go and fix their prolapse and they don't get bladder infections. And I can give you quite a few examples of patients in whom I've done that. And it certainly makes sense from an anatomical and from a physical or physiological point of view. We showed the slide last week and the previous week. So this is a slide that you've all seen about 3 times in the last 2 weeks. But
it's an important slide.
Yeah, I think you've got this in your slides, and I gave it last week. But it's really just checking the residual. If a patient's got a residual, it might be important to address this residual.
What's normal?
You asked me that last week.
Yeah, but not everybody was here last
time. Yeah, I mean, they say anything more than 30 can give rise to recurrent urinary tract infections, but I don't think you would treat it at that level. But, I mean, if it's 150, 200, yeah, that makes sense. This is an abdominal probe. Just measure the 3 parameters of the bladder and times it 0.6, and that gives you the volume in milliliters. And that then indeed gives you the, you know, a little bit more background and an ability to decide whether you should go and do something about it. So when to do a urine MCS, we've spoken about this already, but obviously in a patient who's very sick, pyelonephritis, symptoms that do not occur, resolve, atypical symptoms, pregnant women, and then obviously you've got the whole other reasons, like, you know, you're not sure if it's a UTI, they might have recurrent, you might have a hospital base. Anyone who comes to see you, though, you did a surgery on them, they come back and see you a week later. I think it's important to do an MCS in those patients because you might miss whatever is causing the UTI, and you might give them a traditional thing like Urizone or Augmentin, but there might be something else that you might not hit with your sort of standard type empiric treatment to the treatment of that infection.
Talking about UTIs and intercourse, intimacy. Many years ago, we had Professor Matthew come across and say that a very good way of preventing this, which is a very common problem, is giving a Bactrim after intimacy. Does this still hold, a Bactrim?
No, we're going to talk a lot about that.
Okay.
It doesn't have to be Bactrim. It can be, I mean, you can pick your antibiotic that can be used for that. So then again, well, how do we investigate? What do we do in terms of investigation? You've seen this patient. She's come from her GP. She's been there the last 2 years. She's had at least 3 UTIs in the last year. What do you do? I think you can try and decide with the patients. You know, I think it is quite good to have at least a renal ultrasound. And you know, the question is, do you then go ahead and do a cystoscopy? Now, indeed, it has a very low diagnostic yield, and in this talk we'll have some of this evidence-based little blocks. But there's weak evidence that that you should go ahead and do this routinely. But for me, I do like to do a cystoscopy because I think you can exclude something like interstitial cystitis, which is got a slightly different treatment strategy in my practice. So that is why I do, and the patients do feel reassured that there's nothing else happening there. And especially someone who's had a previous smoker or an older lady that you are worried, then you know, that is important.
If you did 100 cystoscopies in women under 40, how many would you think that have anatomical abnormalities that you'd pick up? I mean, is it common? Is it
very
uncommon?
uncommon? Yeah.
Okay.
So I'm really looking for interstitial cystitis in these patients. Something that you should think about, especially if you know, are a little bit worried about cancer and there are patients in whom you should, then urine cytology is a good middle road to take. So you just take a little bit of urine, put it into absolute alcohol, and send it off for cytology, and they can look for cancer cells as well. So that's also not a bad idea, and it's a very quick way of you know, assessing it.
I know you have found women that have been proven positive for that.
So there we go. You can actually see there's a cancer. This patient had a mesh procedure, and you can actually see the mesh with a stone growing on it. And you know, this would be something that you would need to think about in the patients who's had a previous TVT or previous mesh prolift. You know, all these things that they were doing in the past, or even a sacrocolpopexy where you can see a little bit of mesh. So this bladder pain syndrome or interstitial cystitis, different terms have been used for it and are still used. I still like the term interstitial cystitis because people still know what it is. I think the most recent term is bladder pain syndrome, and painful bladder syndrome was also utilized before. Yeah, well, this is what you actually see at cystoscopy, filling, emptying, refilling. You start seeing these sort of very inflamed hemorrhagic type bladder. And this is an explanation for a lot of these patients who might have a UTI type symptoms, but you don't actually culture anything. The pathology in these cases is a deficiency of the glycosaminoglycan layer. Although we do have different theories for interstitial cystitis, we really don't know what it is. And unfortunately, there isn't a lot of very good active research into interstitial cystitis. So we are in the dark with a lot of this. And even if you heard a talk like Alison Moore gave a talk last year, and you'll see that the guidelines by the societies like the EUA, European Urology Association, would would have updated the guidelines about in 2003 last on this. So people only interested in this condition.
They aren't, but it's so common.
It's not. I mean, there are some companies that are interested, like this company that produces the thing called Cytostat. I mean, they will occasionally pop past and talk to me about it. But that's also. But he'll talk a little bit about Cytostat. So you see some glimmers of light here and there, but again, not a very glamorous condition. Yeah, you can actually see the patient that as you empty and refill, they start to get these very obvious hemorrhages. And when these form like ulcers, they call it a Hanna's ulcer, which I'm sure you heard of, Pete.
Mm.
And in this patient, yeah, we're doing a biopsy because I think it's nice to have a biopsy of this because a good pathologist will then tell you it's interstitial cystitis. And that then helps you to work through the diagnosis with the patients, and then you can decide from there what what you're going to do about it. Yeah, so so what do I do about interstitial cystitis? I mentioned this last week.
Montelukast.
My first line is Montelukast, which
That sounds like a sort of an exotic holiday location, Steve.
It's basically the standard asthma treatment that is utilized in kids and adults quite extensively. It's a mast cell stabilizer. The biopsies always show lots of mast cells, and they're starting to use this new term, mast cell activation syndrome, MAS. Have you heard of it, Pete? But there are people who are starting to give this a more sort of maybe sexy sounding terminology. And there are some pathologists who are now starting to say, well, more than 20 mast cells per hypertrophy field is diagnostic of interstitial cystitis. So there is a little bit of movement in this direction, but we don't really know what to do about it.
Yeah, my feeling is that it's to do with the biome, Steve. We don't.
Well, we can look at that. I think you are making a good point there. And I think we if we can sort out the microbiome, we'll fix a lot of this problem that we're talking about. Not only recurrent UTIs, but also interstitial cystitis. But I'll give everybody Montelukast. I give everyone Phenergan. I do sometimes try the non-sedating antihistamines. And then I've put omeprazole on there. I've tried that in some patients. Other ideas, and this is actually something that is controversial, but I have actually had a lot of success with this strategy. And I'll put the paper on here just so that there is some evidence for this. And this was published quite long ago. The guy who really pushed this hard was James Malone Lee. And anyone who went to Yuga when he was still alive will remember this guy. Yeah, shame he died about a year ago. He was a professor of medicine, actually, but he was a
geriatric.
He was a geriatrician.
No, he wasn't geriatric. He was a professor of geriatrics.
But he was both. He was a geriatrician and he was quite geriatric when he died. But he was a fantastic scientist. He would jump out at conferences and criticize everyone's research.
I remember.
And he really scared a lot of the junior doctors when we were presenting our research at conferences. And so when he came up with this, I did have to pay attention to it. And you can actually see what he's talking about. And he runs a clinic. I dismissed this idea after a patient arrived in my office with this very paper in her hand, asking me what I thought about giving antibiotics to her who had been diagnosed somewhere else for recurrent for interstitial cystitis. And I went to a conference with this Raji Kasria, who worked with him in his clinic in London. And they were at the Whittington Hospital together, where they ran this clinic. And in fact, what they do in this clinic is that every patient who presents with these symptoms get a long-term course of therapeutic antibiotics, and they use cefalexin, TDS cefalexin. And in this paper, their mean of use was 384 days. So about a year of therapeutic cefalexin in patients with chronic lower urinary tract symptoms, very much like the IC patients. So it was very controversial. They have done 2 or 3 other papers on this. They were looking at novel ways of giving antibiotics, but they had not yet got it yet. But and I have employed the strategy in patients who are open to trying a long-term therapeutic antibiotic approach, and I have had success in quite a number of patients.
In that paper,
Yeah,
how many of the patients with LUTS, low urinary tract symptoms, were cured?
about 90%.
Sure.
Yeah, you can go. I'll send you this paper, Pete, but it's very interesting. You can go and look it up. It's really interesting, and so I've got a good few patients in my practice who have responded very well to long-term use of recurrent of bladder infection. So his whole theory beyond the IC and interstitial cystitis and its etiology is he says that you get little persistent pockets of bacteria called persisters that don't give you obvious cultures, but do give you some symptoms. And that's why he makes extensive use of urine microscopy, looking for white blood cells. And if he sees white blood cells, then he'll start them on the chronic therapeutic antibiotics. And he then decides when to stop it when those white blood cells disappear. So they spin the urine down in their clinic and go. I've tried to do that with one of the labs in Cape Town to see if I can send urine off and see if they can see urine, see white blood cells, but I haven't really made that part of any of my protocols. So let's get onto recurrent UTIs proper. What is our strategy? So obviously their lifestyle changes. We'll look at all these all in detail. Then you've got all these complementary treatments. And we'll be looking at a little bit of cranberry, D-mannose, probiotics, Heprex, and Cystastat. Antibiotics still form a very important part of how we treat this problem, including regular daily antibiotics, self-administered. By that, we mean you think you've got an infection, you take an antibiotic. You've got a stash of antibiotics at home, you just take them. And then obviously post-coital antibiotics.
Steve, what's Heprex?
We're going to get to it.
Oh, okay.
And then well, and then this last but the vaccine is the thing that I really want to talk to you about. It's given us a lot of hope for this actual problem. So lifestyle changes, and this I've got this slide from Lisa, the Otani counseling, as she said, don't drink.
You mustn't call her an O'Donnell because she's not that old.
Lisa Slide. She's not
Oh, I thought you were calling her.
She's not, yeah. Okay, but you know, just these things that people talk about. You were talking about don't wipe back to front. You know, it's the older gynecologists used to recommend that. But we don't have a lot of evidence for any of this actually.
Steve, don't drink too little. How much how much water should a person drink?
I always say about 1.5 liters a day.
Gee whiz.
What do you think? Is
I
that
think
terrible?
half that.
I think fluid. I'm not talking about water. We're talking about general fluid intake. Yeah, I mean, I think anything less than that is probably too little, but you don't drink too much either. That also causes a lot of problems. You know, patients walking like, as you said, the sippy syndrome last week.
Sippy, heavy on.
But there we go. So anything less than 1.5 liters a day. As you increase your fluid intake, you do get a reduction in cystitis episodes and antibiotics. This is from the data from Houston et al., but it's weak evidence. So, but I mean, it's something that we need to talk to patients about, and it might help those. Just the basics.
You know, old Alan Ponton used to talk about your weight. In other words, a woman's weight multiplied by something which I can't remember is how much you should drink. Okay. And 8 glasses is a bit too much. I don't know. Because I had a woman yesterday that drinks 2 liters of Diet Coke a day. And I mean, she was just flooding her kidneys. And she was a small, slight woman, petite. And 2 liters of Diet Coke cannot be good for you.
It's a lot. Yeah. All right. So that's that. I think aggressive treatment of atrophy, I think it's still a very undertreated condition in our community. I see a lot of patients coming with from other doctors who just haven't really treated the atrophy.
Oh, what's your favorite?
I'll show you just a slide with the treatment options that we have available to us. But again, the evidence is not bad. Just important to remember that the oral estrogens are not effective. So if the patient's on and the locally administered ones also aren't really that effective. So local estrogen therapy. So we use so you can use a cream. So we've got the Premarin option and we've got the Sinopause option. They both work well. I'm not aware of any randomized trials comparing the conjugated equine estrogen to the estriol. If you want a patient who wants a more natural option, you go for the estriol. but I use a lot of it. I use a lot of Premarin. It's available in nearly all the pharmacies. It was out of the pharmacies for a year or two, but it's completely back and it really works well. So I like giving Premarin. But Sinopause is maybe a little bit more bioidentical and maybe less of an impact on the breast tissue. If you want to be using it in a patient who's got a history of breast cancer. And then Vagifem, it's this little tablet, and it works very well too. But I think in the patient who've got like really bad atrophy, you can see it on the outside of the vagina. I think rather go for one of the creams. They say the Vagifem does dissolve and move out, but I still think that the creams are a little bit better.
Okay,
Do
so
you have a
they're
strategy
best.
on that, Pete?
No, I'm learning all the time in this talk, Steve.
Yeah, good. Okay, so I've had a laser machine in my office for about 8 years now. And it's fractionated laser. I don't only use it for life-changing vaginal rejuvenation, as the Kardashians were calling it, but I actually use it a lot more for patients with atrophy. So basically, it works by you send these fractionated dots of laser onto the vaginal skin, and it activates the cells to lay down collagen, improve the microvasculature, and improve the oxygenation. So that's how it works.
Steve, just before we get away from the Kardashians, I had a woman today that said, would laser cause a reduction in her vaginal caliber because she'd had vaginal deliveries, her vagina was unashamedly patulous. Would it help over there? Does it help, or was that all just?
It is used extensively for
But does
vaginal
it help?
tightening.
Vaginal
It all
tightening.
depends on how sort of or loose it is, to use the term that you
So is the answer somewhat? It helps
yeah,
somewhat.
it does. And I mean, they use, I almost never see patients for vaginal tightening. I just, it's just the type of patients I see. But someone like Natalia Novikova will see patients for that, and it'll come to them. But I mean, we've had patients in my practice with looseness, and in fact, we've had patients who have one patient had not had an orgasm for a long time, and after um, the laser, she reported that she had actually had an orgasm at sex after that. So it's certainly worth trying. It's not cheap. We charge 3,500 Rand per treatment, but it's
Sorry.
but yeah, but it works by shooting these little laser points onto the vaginal skin. This is the little you can actually see what it does. So this is and you can actually see, so it gives a little bit of burning to the vagina. We give a very good local anesthetic cream, and so they don't really feel it. And there you can actually see what it looks like afterwards, and really moves the atrophy from that to that. And even after one treatment, you start to see an effect. This is the histology from Stefano Salvatore's group in Italy, where it takes the vaginal epithelium from that into a much more healthy.
Is that the same patient?
This is their before and after biopsy pictures. So I think it does work, and this makes sense to me. Who does a lot of laser, it certainly works. So yeah, so I mean, where would we use this? You know, you'll get a patient who just doesn't take the cream, or it's not working, and this sort of fast tracks the whole process to get them into a better position. And I must say, it does work. It's not something that we are making up here. It's an option for some patients, but it is my first line. Premin is cheaper and it is more accessible. We no,
Might be useful if a woman's got breast cancer and doesn't want to go for
absolutely.
estrogen.
Yeah, there are lots of patients who don't want to use the Preminence for whatever reason. So we still in the very early phases of what to do about the microbiome. So, but we do like to give patients probiotics. So anyone who's getting recurrent urinary infections, for what it's worth, get them onto a good probiotic.
Which is what?
So we know that having these in one of the things that you give makes sense. So rhamnosus, reuteri, these are the things that you should have in your
Armamentarium.
so Reuterina fem.
Toolbox.
So Recuring FM has got these. So we know about Recuring FM. I like to use Probiflora 9. And there's weak evidence, but there is evidence to say that it does improve that and makes sense. But, I think we haven't done enough research into probiotics yet. And, but everyone who comes and sees me with the recurrent UTI, I get some Probiflora 9 for what it's worth.
Probiflora 9.
Cranberry. Patients roll their eyes every time you say you must take some cranberry, because they've all taken the cranberry juice. They say they drink liters of cranberry juice. I don't advise anyone to drink cranberry juice itself, but there are some good supplements of cranberry. The best one available is this one called Elura. It's got 39 micrograms or milligrams of cranberry in it. There is evidence, and as you can see, that it's weak, but it is there to say that cranberry does work. And the way it works specifically against the E. coli. And I always show this to my patients when I'm showing them with this little picture of the bladder, and I say it coats the lining of the urethra. So it actually sits on here. So it stops the E. coli from climbing up into the bladder. So that's the place that I would actually use it. And so everyone who gets bladder infections should at least be on some E. coli. The Allura works quite well for the acute phase as well, especially if it's in E. coli. Problem with the Allura, it's expensive. It's you only get 15 in a pack, and it's about more than 300 Rand per treatment. So I had a phase where I was giving it to the patients a lot, but it's expensive. All these supplements are actually quite expensive.
Steve, just to get back to probiotics and these things, and especially cranberry juice.
Yeah.
There was not a randomized control trial, but conglomeration done in the Cochrane database.
Yeah.
What was the outcome?
I haven't looked at that recently.
Oh, okay.
Yeah, I should have, I suppose, but I didn't.
Because they said they weren't so enamored.
But I mean, the evidence is there, and it makes scientific sense, and if you can't, it's individualized treatment as well, unfortunately, because your recurrent urinary infection's got a multifactorial background. So it's my favorite supplement now in the last few months has been D-mannose. And basically it prevents UTIs in mostly E. coli as an immune modulator. And it is available now in South Africa. And the evidence, although it's weak, it does seem to work, and it's a very innocuous option for patients, and so I definitely give that. And this is actually the thing I've been giving a lot of my patients the last few weeks and months is Uridine. It's available at Dischem. And if you look at it, it's got cranberry in it. It's got D-mannose. It's got quercetin, which you probably wouldn't have heard of, but it's also quite a good supplement, especially in patients who've got interstitial cystitis. And it's also got green tea in it, and I think it works. I think it does work. It's not cheap though either. But
it's reassuringly expensive.
I give it to my patients just because I'm getting the cranberry and I'm getting the D-mannose. So this is something that I've been using quite frequently to my patients, and it's I don't think it's something that I've had any complaints about. This isn't available in South Africa. Hiprix. It basically gets secreted into urine and makes it basically into formalin, which
your urine becomes formalin.
Yeah, so it increases the formaldehyde content of the urine.
It sounds pretty poisonous.
I'm sorry we don't have this in South Africa because I think it does help. It does work. We can't get it here. I had a patient whose husband was a pharmacist. He was trying to get them to make it or try and ship it into South Africa. We can't get it. But in places you can get it, does work quite well, apparently. Hiprix. It's called Hiprix. Maybe we can still get it somewhere now. I don't know, but I've been unable to get it for patients. But so these things do help, and the evidence is actually quite good for it. So it's Hiprix. And I'm sorry we can't get it because this is a great supplement, and I don't think there's many side effects from it.
But what you'd ask yourself, if it does work, why would we not have access to it? I mean, is it because manufacturers not thought about bringing it through, or is it our blockage?
No one's too bothered by this condition, Pete.
No.
It's not a.
There's no money in it.
There's not a. Well, I mean, there's a lot of money if you look at the amount people are spending on cranberry and Uriclear and all these things that people go and buy over the counter. So it would make financial sense to me, but I think the regulatory,
Urispaz is one of the
yeah,
biggest money sellers of
yeah.
all.
But I think just to get back to that, I mean, the regulatory barriers to getting something like this into South Africa are quite tedious. Someone would have to go to SAPRA and, fill in forms and all sorts of stuff.
It might take 2 years. And
Yeah,
cost
so
money.
I think someone just hasn't bothered. If it affected someone, I don't know, yeah, who was important in this area, might happen.
Alternatively, you go
Yeah.
overseas to India and buy. They probably have it there. If they don't have it, they'll
They've
make
got
it.
it in Australia. They've got it in the UK. Okay, Cystastat is a hyaluronic acid, and that it has been shown to reduce the risks of recurrent UTIs. It's a installation in the bladder, but again, it's about 2,500 rand per bottle.
Sure.
You need at least 4, given a week apart, and but I've been frustrated with managing patients, and I've actually given them this.
Theoretically, it should
Yeah.
also work for OAB because the gag layer is improved.
Yeah, well, it works for interstitial cystitis, and that is actually the patients in whom we use it. But it's not covered by the medical aids. It's been available for more than 4 or 5 years in the country, but it still hasn't been approved by our discovery on any of the other medical aids to be used, even on the patients with decent outpatient plans. Which then brings us to antibiotics. They do form an important part of our treatment option. And so we can give our patients continuous low dose, and obviously we all know about macrodantin, but you can give them Urizone, fosfomycin, 3 grams every 10 days, or even Bactrim. I do use a lot of Bactrim these days, interestingly, Pete, because it's I think the bugs have forgotten about it. So that is something that we can do.
Absolutely no question.
Yeah.
It was everybody's go-to. It
Yeah.
was like Augmentin
Yeah.
20 years ago.
Yeah. So the place of long-term or chronic low-dose antibiotics like a macrodantin is in those patients who you're starting a treatment regime. So they're very atrophic. You want to get the vagina a little bit better. Give them some macrodantin for 3 months. You're working through a strategy to get them improved. We need to be careful on macrodantin because anything more than 3 months, they say, can give rise to pulmonary fibrosis. It's not only theoretical, there are patients who do get it, and if you get that patient who gets it, you might regret giving it for so long. But that said, sometimes patients are so frustrated with this condition that they're prepared to accept that risk, and they might stay on it for up to 2 years. I know Frank van Wyk, who treats a lot of these patients in Pretoria, will continue patients on chronic macrodantin just to keep them stable from a recurrent urinary tract infection point of view. Not a bad idea to give patients antibiotics to keep at home, and it's not a bad strategy. If you like, you got a UTI.
Yeah, I have lots of patients that have it in their purse.
Yeah,
and whenever they get those prodroma, just use it.
Yeah,
it's a wonderful drug.
Not a bad idea. And that's also some evidence for that. And then postcoital, we'll give patients a stash of whatever Bactrim, whatever, and they'll take it after.
So you said there are alternatives. Alternative to Bactrim, what do you use for that?
You can use anything actually. I'll sometimes rotate them. I'll give them maybe 1 gram of Augmentin a day as well. Not a bad idea. Cefalexin is actually a good antibiotic. It's the first generation cephalosporin, not used extensively for many other things, and it actually works quite well. And Bactrim, I don't like ciprofloxacin because of that whole drama with the Achilles tendonitis, etc. So, but sometimes that's the only thing the patients will tolerate. I've got a patient who's allergic to basically everything.
But fosfomycin, I've never yet had a patient that says that's the rubbish stuff because of side effects. Doesn't appear to have any side effects.
Great antibiotic, but and it's actually still very effective. If you look at your urine cultures, Urizone is still very effective, and I'm dreading the day it's not very effective. And there are some good generics available for it too.
Really?
Yeah.
Really?
Yeah.
Every week you tell me about new generics.
Yeah. Time flies, and the whatever patent runs out, and they're able to get cheap generics for these things. Okay, and then the thing that I really wanted to focus on here is the vaccine. So we've got the good news is there's now a vaccine for recurrent urinary tract infections. In fact, internationally there are now 4 vaccines The one available in South Africa is Urimune. It's actually a sublingual vaccine, but there are 3 others that are available internationally. The good news about the one that we have, that it's actually effective against 4 types of bacteria. The others are some of them aren't actually, some of them only have E. coli in them. So the
which
one
are
is
the 4 that
okay. So I'll explain. So there
Oh,
we go.
there
You
they
can
are.
see it there. We can actually just pass me that little box on the shelf there, Pete. I'll show the people what
we've
it
got
looks like.
so many boxes. Which
No,
box?
that one,
Oh,
that
this
one. Yeah, yeah. So this is it. This is actually a sample. So it's this is the Urimune, and it's not. It's just a placebo actually. Yeah, but you can actually just put in your tongue. You go like this. You have some?
Oh, it tastes terrible.
It's
Steve.
pineapple. Yeah,
Gee whiz.
it's pineapple flavored.
Pina colada.
2 puffs a day. It is registered in 26 countries. It makes patients a bit nervous. Number one, because of what we were talking about vaccines about 2 weeks ago, but it's still prescribed under Section 21 because there's still some phase 3 trials happening, but it's extremely safe and it's been available since 2013. So it's
2 puffs a day for how many days?
for 3 months.
Oh, 3 months.
Yeah.
Okay.
Okay, so there we go. It's effective against E. coli, Proteus vulgaris, Enterococcus, and Klebsiella. So it really covers the most important bacteria that we see in that. So in order to get it for the patients, they need to sign a Section 21 form, which the company will provide to you. It costs 3,900 Rand for the full 3-month treatment. So for 3,900 Rand, they get this whole box. And I don't get anything from the company, I promise you. This but they do support some of the the delivery of the whole product. And then 3 months, 2 puffs under the tongue. And to be honest with you, it's been very effective. I've given it to 42 patients now.
42.
Yeah, so it came available in February last year, and I've used it in 42 patients. And my experience has been very much according to the evidence I'll show you now. I've got about maybe 3 or 4 patients who have had some bladder infection since then, but the rest have really been quite happy with it. So there we go. I've given you the live one, but there you can actually see there. So it comes in these 2 little bottles, and they just take up 2 puffs under the tongue. It gets delivered by the company to the patient's home in a little cooler box. Yeah, so it's very nice. So once they sign the form, yeah, they sign it, they pay a 400 Rand registration fee, and then they've got to sum up, pay the 3,900 Rand, and then it gets delivered to them, and then that's it. So it's not difficult. Yeah, so there's actually quite a lot of evidence for it. There are at least some studies on it. This is just a cohort study, 67 patients, and compared to before, there was a 75% had a 9-month efficacy from it, and there weren't a lot of side effects from this.
Apart from poverty.
Well, it's not that expensive, Pete. I mean, the course of macrodantin is probably what about,
same.
long-term macrodantin is probably going to be more.
No, you're right, Steve.
Yeah, so 3 months of macrodantin is going to be, yeah. So, and even in my experience, I honestly can't tell you, of those 42 patients, there's no one who told me about any side effect. Not one. They all fine. There's no one's complaining about anything. So there's no side effects. The adverse events are completely minimal. This is a placebo study, and you can actually see they call it MV140. But again, numbers of UTIs, you can just see these slides. Compared to placebo, the UTI-free periods really are low in the patients who'd had this vaccine. So it's
the UTI-free periods are high.
You can see these different graphs. Yeah, so very good efficacy compared to placebo. Compared to the use of antibiotics, again, remarkably good data in patients who are taking therapeutic antibiotics versus those patients having the vaccine. So very effective treatment, in my opinion, with some really good data to point in direction. There is now this systematic review, 19 studies on Urimune. So you can really reassure your patients that this is something that has been investigated, although they're signing a Section 21 paper, waiver on it.
Is his name really Curtis Nickel?
Yeah, looks like it. Why?
Unusual name, Curtis Nickel.
So yeah, we can actually see these are the papers on it. And you can actually see it's been studied in quite an extensive array of patients. And if you just look at some very basic numbers here, um, anything between 60, 80% of patients UTI freeze at 12 months in the study, 65.
It's
Yeah,
remarkable because
not
most
bad.
of these patients have tried everything
Yeah,
else.
so it's not bad. I mean, I tell my patients, that it's probably going to be
80%.
about 75 to 80% effective. And that
It's
is
worth it.
what I've experienced in my
If
patients.
you if you say 4,000 rand for
Yeah,
something that works
yeah,
versus just go try and have a cystoscopy and see how much that
yeah,
costs.
yeah, yeah. So that's all about the vaccine. Lindsay from New Angle dropped this at my office. You can actually see it's another thing on my shelf here. Pass me that bottle there, please. I actually, yeah, I got dropped at the head about the talk. This micro docs. I don't know if anyone's got experience from it, so maybe we can look at the questions.
Did they
It's
give
a
you some
installation.
sponsorship?
No, they just dropped this in my office. I
Oh,
don't know what it is. Maybe Lindsay, if she's on, she can maybe even give us a bit of a content.
Microdox
It's like a,
is a bladder rinse solution
yeah,
for use as an adjunct to the treatment of urinary tract infection.
yeah. So I mean, it'd be interesting to. This is just hot off the press. It was just dropped in my office when they heard I was giving the talk. So maybe this is something you could all be on the lookout for. I'll try to get some information from it on the internet, PubMed. Very little coming through, but it looks like it's more used in catheter-associated infections, flushing the bladder too. It's hypochloric acid or hypochlorous.
I know hypochloric acid and sodium hypochlorite.
Yeah. So, and this is I think this is used a lot in some inflammatory conditions. But just in summary, make the diagnosis, investigate where appropriate, go for your over-the-counter things like your cranberries. I like D-Manos, cranberry, as I said, and then treat your patients with atrophy. Antibiotics do unfortunately form an important part of how we treat these patients. Don't forget about your probiotics. Think about the vaccine. It is useful and it is available to you guys. And I mean, I certainly think that you could get support from Euroimmune. It's actually made by Immunospec. That's the company, and we can try and get that information to you if you want. So yeah, that's the talk, Pete.
Steve, this has been a wonderful afternoon of information. I've learned a lot. I always do. Katrine Middleton says, what is your experience, Steve, with recurrent UTIs and undiagnosed small rectovaginal fistula, mostly after TAH? Could you answer that, please?
Yeah, I mean, you need to think about that. But I mean, I think by then the patient would probably have some symptoms of some leakage as well. But yeah, bad luck to have something like that. But
well, if she has, just
yeah.
to get back to your point about cystoscopy, if a woman has recurrent urinary tract infections, how many of those would you do cystoscopy on?
By the time they get to me, I do invariably do a cystoscopy.
Yeah, well,
because
see,
I
then
just want to check for something. You know,
Yeah,
I'm
then
a
you
bit
might-
nervous missing or something. It's it's paid for by the medical aid. They spend like a few hours in hospital. Patients are very happy to have that. Just
you probably pick up
something reassuring about it.
fistula then
Yeah,
at your
you know,
cystoscopy.
they're very anxious patients. They're frustrated, and just to know that you're doing something to exclude a serious condition does help these patients process the problem as well. And you can see interstitial as one of these patients.
Yeah, Steve, I think that's when a cystitis, when I'm trying to read the next question.
Oh, there isn't
It's over there.
It's there. Oh, sorry. How do you order Euroimmune? Yeah, I asked my secretary.
See, that's not an answer. It's not actually an answer.
You need a setup. I'm sure people are going to now ask how to do it. There's so you need to interact with the rep in your,
All right,
your
I'll tell
company.
you what.
But
Give them that email address there, Steve.
yeah. So there we go. So I think this is the best. So maybe you want to take a screenshot of that. But it's Immunospec is the company. It's info@immunospec.co.za. IMMUNO spec SPEC.co.za. And you maybe get hold of them directly, and you'll be able to
They'll drop it off.
yeah, you don't need to be a specialist or anything, and I don't think it's got a lot of there's no adverse events. Just make sure you're not missing something important. That's probably my advice to you. And but I think the average sort of general gynecologist would be well to use it as well, as long as you know that you're not missing anything important.
Steve, it's been wonderful. In the absence of any other questions, the third question there I'm trying to read as well. Willem Combering says, any place for hydrodilation with cystoscopy? I suppose that's the painful bladder syndrome,
Yeah,
Steve.
no, it works in some patients, but it doesn't last very long. It lasts for a few days, maybe a few weeks. But yeah, I mean,
It's an old standby in
but,
interstitial cystitis.
But the one thing that I don't think works and that is done by most urologists is
Urethral dilatation.
Yeah.
Oh, yeah,
There's no
sure.
data on that, but
Why
everyone
do
does.
you do it, Steve?
I don't know.
I don't know if any
I don't know.
urologists.
It's an old-fashioned thing, and yeah, I don't know.
The old guys
I
all
don't
did
know.
it.
I don't, and I wanted to do a good review on it, but it does work in the odd patient might have a good run after the cystoscopy for some reason, and then they you know, some people think it might be due to some urinary retention or something, and the dilating the urethra does help a little bit, but yeah, I don't really think it works, and it and I think there is a code for it in urology, to be honest.
No, I'm sure there is, otherwise they wouldn't do
There is
it.
a code for it, and yeah.
With respect.
But urologists might be better at working these patients up as well anyway. So, you know, I mean, if he's a GP out there, it might be better seeing them to urologist anyway.
Why?
Well, I think that they urologists do more cystoscopies. They might be a little bit more in tune to something more serious. So, yeah, so I mean, that's kind of maybe more of a gut feel. But anyway, that's
our talk. Ladies and gentlemen, it's wonderful to have so many people on this talk tonight. It's a sort of a testament to Steve's popularity. And we're going to have Dr. Femi Laragon next week. But just before we get to next week, a quick reminder that we have FIGO, the International Congress over here in October, the beginning of October, this year, no longer next year, it's now this year. In a few months' time, I'm going to invite you all to Cape Town for this magnificent International Congress. We start with workshops on Saturday, the 5th of October, and then there's a full week ahead for the general ONG person, including wonderful plenary talks and also even a couple of nice dinners and parties. So bear that in mind. Please put it in your diary, the beginning of October of this year in Cape Town at the CTI-CC, which is within spitting distance of Steve's office. So, ladies and gentlemen, thank you once again, and a special thank you to Chris, and a very big thank you to Steve. It's been wonderful, Steve. We're on 6 o'clock, so we have to sign off, unfortunately, because we're running out of bandwidth. But I'll see you all same time, same place next week in this venue. Thank you, Steve.
Thank you. Thanks, Pete. And yeah, pleasure to have given this talk, and we'll see you all next week. Thank you.
Hands-on and practical as always.